Okay, we're set? Great. We're going to get started. First, hopefully all of you have seen the notice, but today is a day for celebration. For those who don't know what we're celebrating, Rob Califf today made one step closer to finally making FDA commissioner. He got through, this is actually the very big hurdle, getting through this Senate committee vote. Pretty much, though nothing is assured in Washington these days, but pretty much assures that he will be on smooth sailing. The final vote by the full Senate has not yet been set, but that should be coming forth right, and he will take on his position. So definitely go to the website, check it out, and feel free to write Rob nice little notes. I'm sure he's getting just a couple today. It is fitting, though, that in fact this year has begun with sort of major events in this regard. We got Rob Califf coming into this office. You had last week Leslie, Adrian, and others presenting a remarkable look at how and where we're coming with regards to changing around how we do clinical trials. Today, we're going to see a pretty interesting presentation on where the world of implementation science is and how are we learning more about what it is that we're supposed to do and ultimately are doing. The talk is going to be given by a lot of us, so that'll be first the challenge will be to get through this many people in this little short of time. I'll give you brief introductions on some of these. First of them is Vincent Miller. Vincent, you can stand, Vincent. Vincent is a graduate of Tufts University. He has been here for a mere 20 years at the DCRI, a newbie. Relative to Laura Webb, who is a UNC grad. I didn't know that, Laura. There was always some rivalry, and I knew there had to be something. Right? Laura has been here for a mere 21 years at the DCRI. Each of these guys have been incredible stalwarts within the outcomes group and have moved up progressively over the years to leadership positions. We also have Anna Marie Navarre. There she goes. A relative youngie into the DCRI fold. She did her undergraduate at University of Texas, here for medical school, then a residency here, so far good, and then off to Hopkins for a PhD before coming back here and doing her fellowship. We are hopeful that we will soon recruit her onto the faculty. And then last but not least in this series is Tracy Wong, who did her undergrad at Yale, her medical school at Harvard. Then she went for residency at Brigham and Women's and then down to Duke for fellowship and then has stayed on ever since. So it's a kind of a slouchy crew, but we'll do our best. And the topic today is the Palm Registry. So if we get to the point, if you take sort of off last week and we get to the point where we actually get the studies done, we show what works. It's very clear from a patient perspective that actually applying that knowledge into routine clinical practice is what we need to do in a rapid fashion that's going to be complete and accurate in treating the right patients each time. Unfortunately, in American medicine is all too apparent by this wonderful report that came out of the Institute of Medicine, Crossing the Quality Chasm. That doesn't happen a lot. It is slow, it is incomplete, it is inefficient, and it's a problem. This idea that we need to not only get great discoveries from the bench into the bedside and through the clinical trials and ultimately onto the market, but that we have to worry a whole lot about that second step from the idea of now once it's on the market, can we get physicians to accurately assess who needs this, to then apply the medicines, to then to get patients to take it, and then ultimately to adhere to those medications long term, so that ultimately we can live out the dream. We can change the outcomes, make patients better. We have used clinical registries over the years as a means to sort of monitor this, partly to inform the evidence process itself, but also to determine, once we have determined what the great evidence is and summarized it into guidelines, do we actually apply it routinely in practice? If you ever ask clinicians, we always do it. And it's only when we start to measure it that we find out that, lo and behold, a lot of patients that we thought ought to be eligible for these therapies are not routinely getting it. So registries have become a profound tool to both measure, monitor, and ultimately lead to quality improvement. We've used them as an example. Here's a Crusade registry, a very early one, published around now almost 15 years ago, looking at the routine use of evidence-based therapies at this time, simple things that were used in treatment of patients with heart attack or myocardial infarction, and found that even in the best centers across America, those in those yellow bars, top quartile of the US, there was wide underuse of medications that are simple and easy to use. If we look at the red bars, the lower quartile of care, we see there's marked divergence or variation in the degree of practice that's being given to these patients. And what's more important is when we associate the quality of care or adherence to those guidelines to actual outcomes for patients, we found that in fact those patients that adhered more frequently or that got these medicines more frequently actually did better. Mortality was significantly lower. The medicines in part worked, and in part this was a marker for the quality of the institutions that were providing this care. If we turn this around to looking at current ideas, not the idea of treating a disease, but the idea of actually preventing it in the first place, prevention is an incredibly powerful tool. It's probably, if we looked at, we just did a review with the Medicare and looked back at predictions that we'd made 15 years ago about what was going to change medicine the most. And at that point in time, we predicted all sorts of funny things on the development of new technologies. But the one we got right, and actually has been most profound, is the more frequent and consistent use of prevention in routine practice and how it would change medicine. Guidelines have recently come out that summarize the evidence from clinical trials that show, in fact, that our old guidelines perhaps weren't exactly right. There was a large emphasis just on an LDL number. Now we're looking at the total risk of the patient. There was an idea that, in fact, if you have disease, you ought to be treating people with higher doses of statins to get people down to the levels that have been shown within clinical trials to actually be effective. So these were changes from where we had been, and in fact caused clinicians to rethink the sort of heuristics or basic patterns we use to treat patients. They also put a lot more patients at risk for statins, if you say it the other way, or may benefit from statins. So up to 12.8 million people in the US potentially would be now eligible for statins that hadn't been eligible from the prior guidelines. And in fact, it was seminal work done here by Michael Pensina, Anne-Marie Navarre, and others that actually showed how big this gulf was. Just as one way of sort of looking in general at this idea, the sort of lighter bars are what we're actually receiving treatment in routine clinical practice. And then if you look at what the actual guidelines were now saying, a whole lot of people under the newer guidelines, the second bars, the ACC-AHA guidelines, were now eligible for therapy that hadn't heretofore been treated. So we wondered the following questions. Once these guidelines had put it into place, how routinely had clinicians a couple years later adopted those therapies into routine clinical practice? And more importantly than just documenting the problem, which has been what we've done in the past registries, could we start to work towards what are the solutions? What are the underlying causes that are driving these changes, and what can we do to make it better? In part, this gets to this beautiful diagram of understanding what it is that makes physicians, patients, and systems work. So in fact, to get a therapy used routinely, providers have to be aware of what the evidence is, accept that it's the right answer, and then apply it routinely. In addition, if you look at it from the patient's perspective, there has to be engagement on the part of patients, something we're emphasizing more and more these days. The patients also have to understand they're at risk, that there are therapies out there that they can benefit from, and understanding these risks and benefits, ultimately be engaged in the process of taking the medicines. You accept it and you take it. Finally, there are systems that in fact can either impede or promote the idea that we would routinely use these. So when we come to the idea of prevention and use of statin therapies routinely in clinical practice, it comes down to these questions. Do clinicians understand what the new guidelines said? Do they buy into them? Was there a failure to practice what we preach? We can tell you what the right answer is, but we just don't do it routinely. Or was it issues with patients? Did they not understand that they were at risk for disease? Did they overestimate the side effects or tolerability of the medications? How did they weigh the risk and benefits of treatment in their case, if they look at it from a short-term perspective or potentially even over a lifetime? And then finally, how's the system set up? Is there a number of how many people are seen in the clinic, decision supports, and et cetera? So this led us to PALM, which will be introduced by Tracy.
Thank you. I think this works. Thank you. Great. Thanks very much. I'm going to spend a few minutes kind of setting up what the PALM study was supposed to accomplish, and then some of our sort of guiding principles as we thought about designing this study. And then I'm actually going to turn it over to the folks that made the study a reality here. And they're going to show you some of the things that we are really proud of, I think is really cool, and I think really changes the paradigm for how we think about doing research in the future. So thanks to Eric in terms of the background here. what we were faced with were really the following study questions, if you will. So to what extent were those new cholesterol-lowering guidelines adopted by us in routine clinical practice? Where are the gaps when we try to implement these type of guidelines? Most importantly, if we think about how to implement care, that's a partnership between the clinician and the patients. And it's really important for the patients to really be able to work with us in partnership here. So how do patients think about their cholesterol management? And as you've seen from the latest guidelines, they're no longer so much based on numbers, what the cholesterol level were. They're really a lot more based on risk. How high of a risk is the patient for future events? So how do we marry the number to the risk, help the patient understand that, and then be able to treat based on those concepts. And then finally, at the end of the day, how do the clinician and the patient come together to try to overcome these barriers so that we can move to a healthier population in general? So in order to do this, we really needed all of these inputs. So I'll start at the bottom. We have what we traditionally have needed within a clinical trial setting. We needed information about the patients, and we get that from the medical record. Sometimes we needed to get laboratory results for the patient, and so there's a core lab component. Those are things that are not really that surprising to us. But the top of the slide are things that we needed to collect. We needed to understand how the providers thought about therapies, how they implemented the guidelines. We thought it would be helpful to directly query the providers that information. It was also helpful to give them hypothetical scenarios. So that was part of the provider survey. And then on the patient side, we really, really wanted to understand how patients thought about risk. So there was a patient survey component here, and we'll go into that in a little bit more detail later on. But altogether, these are really what form the components of the PALM study. Now, I put this in here because when we think about research, and this is a study that we helped with, when we think about the patients that we enroll in research, they're really such a small fraction of the patients we treat in routine care. So this is a MI population. We are basing how we treat patients on 3% or less of patients studied in our research trials. That's abysmal. I mean, how do you take something that applies to 3% and apply that to the rest of the 97%? Okay. And part of the reason is because sometimes there's a little bit of that barrier to patients participating in research. And so this is one of the key themes here for our innovation is how do we get patients to participate in research with us in a way that is enticing, it's interesting, and it helps them and it helps us. We wanted to, we've always talked about site management, making sure clinicians are interested in the research that we do here, and that's certainly part of this as well. We wanted to make sure that our research is efficient, yet at the same time we're collecting good data, high quality data that we can really get very useful insights from at the end of the day. We'll talk about new technology. That's a key theme here because we think that technology really plays a role in how we think about doing research nowadays, and especially how we innovate pragmatic research design. So these are some of the innovation goals that we listed for ourselves at the beginning of the study. Now, this is a study that we did here at Duke where we looked at all the patients we tried to recruit into a clinical trial. So these are patients who are eligible for clinical trials. And so we screened these patients, they screened in, and at the end of the day we looked at how many actually participated in the trial. And then we tried to figure out what made a difference. And I don't want to go into all of the data, but the number one most significant factor was how the trial was set up for the patient. If it was too intensive, it was too scary, that was a trial that the patients were just going to say no to. And that factor is more important or more significant than many of the other characteristics that we think about: age, sex, race, things like that. In fact, race was no longer an issue here in North Carolina, which was a nice finding from this study. So that meant that we need to design a trial that really sounded easy to the patient or sounded more approachable to the patient. And the first barrier is the informed consent form. We need their consent to be part of a study. Has anyone in this room participated in a research trial before? Excellent. Okay. So one of the first things you sign is a 6-page form. And this is just for a registry, not an interventional trial. Okay? So that's the first barrier we need to deal with here, is how do we help patients deal with a 6-page? It's actually, it is 6. There's a 7th page, I guess, for a signature. Thank you. I thought I clicked the right number of times here. But that's really the first barrier here. How many patients, how many of you have seen a doctor here in clinic? Come on. More participation, please. Okay. So you guys are really familiar with the clinic process, right? You start out in a waiting room, and you wait, 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 and then someone is going to take you somewhere. They're going to get your blood pressure, check your weight, unless you say, no, thanks, I'll do that next year. And then you might go back out into the waiting room, and you wait, and you wait, and you wait, and you wait. And then you finally get escorted into the clinic room where the doctor spends some time with you, or the advanced practice provider spends some time with you, and you go through all the things that you kind of expect from the clinic visit. And then they say, well, maybe we should get an EKG on you, maybe we should get some blood drawn. So you go back out into the waiting room, and you wait, and you wait, and you wait. And then they call you in, and they draw some blood. And then you wait some more, and then they call you. So you kind of get the sense that there's a bit of a downtime, maybe during the clinic process. Okay. And how many of you have seen this in the waiting room? Yeah, I mean, what the hell do you do there, you know? So fortunately, all of us have iPhones or something that distracts us nowadays, but, you know, people are bored in the waiting room. Now, notice the smirk on this guy's face, because he's got something in his hand that really distracts them, right? So this is kind of what we did. Now, the other thing is we've, obviously been, it's DCRI. We're all about research. We talk to sites all the time. And we ask sites, what are must-haves in terms of being able to successfully enroll in a study? And these are some of the comments here, and especially this is a question targeted towards how can we get patients in the outpatient setting to be part of this study? And so these are some of the comments there. It needs to be portable. I don't have a computer to sit the patient behind all day. The patient can't take up a clinic room all day. It needs to be easy. It needs to be user-friendly. It needs to be quick. It needs to be fun. The patients need to be able to read the text. It needs to be enticing. Preferably, it needs to be completed within a single visit. On our end, we obviously have to worry about some of the regulatory aspects of it. Is it IRB compliant? Is it secure? Is it controlled? Can we, all of these things. So these are some of the must-haves that are really critical to how we design this. And so what we're going to show you here is an iPad app that was born and bred here at DCRI, which really represents a sort of a one-stop shopping kind of mechanism here. It's one device. You get to do the screening on the device. You hand the device over to a patient. The patient goes through the consent process on the device. And then when they're done with that, the device stays in their hands, and they do the patient survey piece of that. And then the device comes back to us. And the device is really planned to adapt to the busy workflow of a clinic. We're not trying to tie up space here. We want to make sure the patient's workflow continues, but we want to take advantage of that waiting and the waiting and the waiting time, right? So we're going to use that time. The patient's captive. They're not going anywhere. We want to take advantage of that sort of captive audience to get them engaged in research and complete the work. And we don't want to have to copy data into someplace else later on. So it's paperless entry. You enter the data once, and hopefully you enter the data directly, and you never have to recopy this into someplace else. So it's direct paperless. And so with that introduction, I'm going to bring up Vincent.
So it's actually kind of different to be up here as opposed to walking around the lab at the hospital, chasing down patients for Tracy and Eric. So the app was basically made to make the user interface for the coordinators easier, as well as Tracy said, engage the patients, as well as give them a voice. I think giving them a voice is key. You get them to want to voice their opinion, their data will triple, is what I like to say. So with the app, the screening form is the first thing that you see when you open up the app. Basically, the screening form that we created is adaptable, meaning it lets you know when a patient is eligible based upon the information you put in. For Palm, in this particular case, we made the first 3 fields required. So every single patient that was screened in Palm, whether or not they participated, we had that data. So no more with the paper and the site does not report the information. They had to put this data in, and now we have it. We don't have to worry about chasing it down. At the bottom, for those coordinators that were worried about whether or not a patient participated, they were borderline, the app takes care of that for you. Basically, with the answers that you provide, at the top of the page, it's going to tell you thumbs up if they're eligible or thumbs down if they don't. Once you complete the actual determining of eligibility, you're taken to the next screen. So again, we wanted to make it intuitive. The coordinator is taken to the 3 different pathways. If you walk up to the patient and determine that they are not eligible for whatever reason, they're not mentally sufficient or any number of reasons, you would take the ineligible path. If you mention it to them and they decide that they don't want to participate, you would go ahead and choose the decline path. But like everybody in here, we want to see what's behind the consent door. So we would choose the consent path. With the consent, basically, we took the consent and came up with 2 different versions, right? So the video is the version on the left and the text is the version on the right. The video is key. We used Duke Communications and some people that I told would be stars that are here in this room. And we used Duke staff and basically created a 6-minute video to go along with our text version of our consent. It's the exact same thing as the consent form. It covers the exact same material. The idea, though, is we input vignettes. And like I said, I see one of the stars up here up front, this DJ. Your face has been seen by well over 2,000 patients at 150 different sites across the country, right? But again, the idea was to make it usable for the patient. We wanted them to engage in the process. So if you chose the text portion, you could enlarge the print if you forgot your glasses. If you didn't really want to, you wanted to look at the video, you could look at the videos, and we took it a step up and turned it into a game, right? So the idea is you give the patients a feeling of accomplishment, right? They can go through and choose the videos that they want to watch in any order. They could also, in this particular case in Palm, like Tracy mentioned, we wanted to enroll patients in the clinic while they were waiting. So you could literally hand them a device, set them up right here, and they could watch the videos while they're waiting. Coordinator doesn't have to do anything. Each video starts by tapping on the screen. At the end of each video, you have what we call sectional consent, right? So you could say, yes, is your affirmation that I do understand what's going on. It's the same thing as initialing each page, essentially. Or you could choose a question mark. So when the coordinator came back to you, or if you were there, they would know which section of the consent you had a question on. They could answer your question. The patient could then change the question mark to a yes. Once you had yes on all of the screens, you would get the done symbol at the bottom. The idea is when we needed to get everything through IRB, thankfully Duke Communications helped us out with that, and we shot videos over and over and over again. You didn't want to have to shoot the entire video over again. You wanted to customize it, you wanted to add contact information for a particular site into a section. You only had to take out 1 section of the video. Each video was about 45 seconds to 1 minute and 20 seconds long, so we didn't have that long drawn out 10, 15 minutes of sitting there trying to figure out when is the end coming, right? The other thing that happens is it illuminates the pathway of the logical step, but the patients could go in any order that they wanted and they could watch them as many times as they needed. I just realized. So once you actually click on the video,
Click on the bottom to play the little triangle at the bottom.
Hi, my name is Anne Marie, and I'm a cardiologist at Duke working with Dr. Tracy Wong on the Palm Registry. Approximately 7,500 patients
So like I said,
from
now that would be
175
2001,
clinics across
right?
the United States will participate. In order to participate in this study, you will have to complete the following activities during today's clinic visit.
Thank you. So once you click on the video, it starts immediately. The volume's automatically turned on, so you're good to go. And literally, the coordinator just has to sit back and answer any questions that the patient has. The idea, again, is you want the patient to be engaged. When you finish with the videos and you're finished with the consent process, we include the signature capture, so anybody that's been to the grocery store and uses their credit card, you've seen this before, you use your finger or a stylus, and basically you sign the consent form to ensure IRB compliance for all sites across the board, whether you're a Duke site, using central IRB or a local IRB. We included initials. We can move the initials around on the page. We can move the signature around on the page wherever you need it. So we could actually upload a site's particular consent form, slap the signatures where we needed them, and ensure IRB compliance. All of our signatures came with date and timestamps, which is a big finding when IRBs do audits. They don't always have the signature, they don't always have the initials, they don't always have the time and date stamp on there. All of ours do. Once they finish with the actual consent form, they're given the option, it's not up here, but they're given the option to actually print or email the consent form. Using Wi-Fi technology, you can essentially take the consent form that's on the device, send it to a wireless printer, or using a secure email, you can actually email it to the patient. So the patient has the choice of how they like to receive the information. Basically, the initial feedback has been awesome. Everybody knows I love that word. Awesome is the word of the day. Basically, we started out from platform and we had about an 8.5 minute video that we created using the last 10 patients of platform, and the patients loved it. To the point where, unfortunately, we didn't have any more patients, so Tracy and Eric got together and we decided we were going to use this concept on Palm. With Palm, essentially, you could say a year and a half later, we are sitting here and we have 7,500 plus patients enrolled at 150 sites. So I think it's safe to say that was a success. We did that in less than 6 months. For all of those patients that were here, they loved having their voice heard. They loved interacting with the app. For the coordinators, that quote at the bottom, I'm sure for any coordinator that's in here applies. You didn't have to walk around with a whole bunch of paper. You didn't have to walk around with a file cabinet on your back, basically to enroll a patient and then come back in and log the information. Some sites actually took it a step further. You had the option to email. You could just basically email this to your secure server, right? And you had all your consent information there loaded. The only other comment that I wanted to put on here, I don't see the quote on here, was a quote from actually a coworker that I wanted to share with you. So basically, like I said, in less than 6 months, we enrolled 7,500 patients, which gave us a lot of data that we now have to interpret. But the quote reads, "Imagine what happens or the changes that can be implemented when you not only increase the amount of data, but also the willingness of the participant." So there's a second part to this. There's actually a survey that we also put on the device, right? And I think Laura's going to talk to us about the survey and what we use for that. That's some pretty interesting technology. I see all the IT people in here who helped us put that part together. It was a tremendous undertaking.
Okay. Okay, so you guys have heard about the survey, you've heard about the consent. One of the things that we needed to do in the survey was gather lots of information. On paper, the survey was like 40 some odd pages. It was crazy. So we had to adapt that. We couldn't spend 3 hours having the survey filled out. So one of the first things we did was create what we called an adaptive survey, meaning that based on the patient's response to a question, the survey branched. They were only presented questions that applied. And the first questions that we started with were about their experience with lipid-lowering therapy, initially with statins and then also with some of the other non-statin agents. So these were sort of the key pivot points at the outset to determine the initial path for the patient. We also had these questions answered while the patient was sitting with a coordinator. It gave us two different aspects of that. First of all, the coordinator could sort of orient them to how the tablet worked, how they would progress through the survey, but they could also ensure that since these questions were about therapies the patient was on, that these questions were answered accurately because they did determine the rest of the data that we were going to gather about this patient. The other thing that was built into the survey was what we've called a randomization. So you've heard Eric and Tracy talk a little bit about how the guidelines center around risk now rather than a number. Well, we wanted to see, what do patients understand about risk? If I say you have a 20% risk of something, does that number mean something to you? Can you apply it to yourself? And so we looked at different ways to present risk, using some of these smiley faces, bar graphs, or no graphs at all. We also looked at different patient scenarios. Did patients understand the concept of risk over 10 years versus risk over their lifetime? And what numbers, what presentation made them say, maybe I should think about doing something about my risk? Does that change whether I'm willing to take a medication or follow a particular therapy? So we actually had, sorry, I'm advancing slides and I don't even know it. So we actually had 6 versions, if you will, of this particular set of questions. So that was also built into the survey, and we had to ensure that we had distribution of those questions roughly equally across our 7,500 patients. And so the devices had to randomize or present those survey scenarios in roughly equal proportions. So this was another real challenge, and one that the IT team, I think, tackled very, very well. I have to say they were all wonderful working through this. At the end, again, we've talked a little bit about the ability to randomize the survey. We wanted to keep the survey to about 20 minutes. That's about what we piloted, and in general, that was the average time. We had some, obviously, that were shorter. You have some that are longer, but we had to keep it a reasonable length of time, or you're going to lose the patient's attention. So then all of these data sources then come into the DCRI. So you have the data collection on the tablet. So again, you've seen the screening, the consent, and the survey wrote directly to a database here at DCRI. We receive core lab results, a lipid panel on all patients. And then we also have the medical record abstraction as well as a provider survey from a couple of different online mechanisms. So then on the tablet, from a site perspective, this is what the coordinator sees. We focused a lot on the patient, but from a coordinator perspective, this is also something coordinators had to use. So a summary page gives them information about what site they're signed into. So if they have more than one site, they can be sure they're entering data in the correct site. They can see a summary of all the patients they've enrolled and what the different patient statuses are as they move through the device. And they can also see if they haven't sent data in a while. One thing we built into the app that was key for the IRB was to limit the amount of time data stayed on the device, because it's a security issue, it's a privacy issue. So there was a time limit that if they weren't on Wi-Fi and the data weren't transmitted, the app would stop working, which would force them to actually sync to Wi-Fi and transmit data before they could proceed. So this was actually an alert to them to say, hey, you're getting close to that time, you need to go where you have active Wi-Fi and make sure you send in data. Again, also for the coordinators, a drawer that enabled them to jump around to different patient records. Patients could stay in statuses for a while. So each site had a couple devices. You might have a patient that does the consent, but then the provider comes in. And so that device may go to another patient to start, and then come back to the first to then go on to the survey. So sites had to be able to jump around to different patient records and different statuses. They can also filter the list, again, to make it easy to go back to these records. And you can see what they're actually looking at and what status they're actually viewing at that time. So it had to be something that was very nimble for the coordinators to use. We also had a nice ability that we could actually push out additional materials to sites. Not only the application, but also iBooks, which contained our reference material for the application. We were able to push out site newsletters. We also, just as an example, we could also even push them directly to the desktop. So for example, the PALM protocol up there could actually sit on the desktop. So you had a couple of different delivery methods for additional site resources if you needed to use it. Also within the device management software, we could send messages that appeared right on the devices. Hey, you need to call us. We realized your app's out of date. We used that a few times. So the device actually gave us a very direct communication and one that was very live. Literally, we could send a command and 30 seconds later you'd be getting that phone call. So lessons learned. So this could be a really long section, but I'm going to try and make it really, I'm going to try and condense it here. Obviously, I think anyone on our team at times could relate to the picture of wanting to just take a hammer to the devices. But in the long run, I think as an organization, we learned a lot, and we really can leverage what we've learned. Wi-Fi access at clinics, that was a requirement for our sites. What we didn't know is that characteristics of the Wi-Fi really, really mattered. Some people have great Wi-Fi, boom, it's easy. Some people think they're on Wi-Fi but aren't really, and some people, their IT won't even let them connect a device that's not theirs to the Wi-Fi. So we learned there are some additional questions and things we need to understand that made a big difference. Video consent. If sites wanted to customize the consent at all, so for example, we had some sites that wanted to pay the patients. If they wanted to customize it all, we couldn't really adapt the video, and so we had sites that used the video and loved it, but we also had to think about what are different ways that we can customize maybe for a future use. The video was very interactive, very well received. Data security. We met with the IRB a couple of times before we actually implemented the application live to make sure that they were comfortable with what we proposed in terms of a data flow, in terms of what was our responsibility to secure and what became the site's responsibility to secure. Again, how long the data remains on the tablet. Are we storing copies of the consent? So things like that that are specific to a mobile device that don't necessarily apply when you're working with paper. So we had to sort of make some of that, come up with those answers, and it varied at sites as well. What happens if the devices don't work? For the most part, the devices worked. We were able to get app updates out. We were able to get data in-house. We've got more than 7,600 patient surveys in-house. So it worked, but there were quirks. There were hiccups. And what happens, and how do you identify those hiccups? What do you do to try and prevent that on a device level as well as on a site capability level? And what questions do you ask up front? Software updates. So not only updates to the application and enhancements to the application, but what happens when Apple rolls out iOS 9? We're on iOS 8.3. Does the software work? Does the application work? Can we even manage that device anymore if the site implements that update? These are things that we had to sort of tackle as we went along. And then at the end, okay, now we've enrolled all our patients. We've got 300 devices out across the US. Now what? What do we do with them? Where do we store them? What do we use them for? So there's also that process not only for the devices, but for this electronic data. How do you store it? How do you sort of close the loop on these different things? Palm was entirely electronic. We didn't collect a single piece of paper for regulatory, for consents, for data. So it's a new thing. How do you store it? What do you tell sites about storing it? So lots of things we had to learn as we went, and we're hopeful that other folks here at DCRI can take what we've learned and add to it and grow on it. So this is an enrollment curve. So you've heard the numbers. This is actually an enrollment curve for the study. So the original bid, this isn't even the original enrollment curve, I'll tell you. The original bid we put out had us starting in January. But because of just getting things going, we had to adjust that to start at the end of March. We didn't actually start enrolling until May 27th. So we're about 5 months behind where we originally thought. Our original enrollment projection was to end in October, and we finished on November 12th. So despite all of the things that went on, we finished only a couple weeks after what we originally put in the proposal, which was just astounding. Not only did we do it way faster than we thought, but we actually had to decrease the number of sites that we enrolled because enrollment was going so fast. We were never going to start up 175 sites before we enrolled 7,500 patients. So we actually backed it down to 150 sites. And in the end, 141 sites actually enrolled patients. So the capture rate of sites was extremely high. Study enrollment, we had some sites that maxed out their 150 patients in a matter of weeks. So it was just beyond, I think, anything we could have imagined from that perspective. And I'll again say the team has been fantastic. IT was amazing. We got to be very close with the IT folks. We spent hours developing the app with them, troubleshooting, after hours sitting around a table trying to start up devices because we couldn't figure out why they wouldn't get going when we turned them on. I mean, so they did a really, really fantastic job, I do have to say. And just lots of different kinds of patients enrolled. Median age of 67 years, but the oldest was over 90. So there wasn't a lot of fear. You know, one of the things we hear is that older patients may not like technology. That's not really what we found. We didn't have any trouble at all getting patients enrolled with this technology. Almost half of them female, 9% African American, and 42% with cardiovascular disease. So there's a good representation of the primary care population as well, which is not necessarily where DCRI comes from historically. So that's a really nice to see that distribution. So I think with that, then we're going to circle back to the science and let Anne-Marie talk a little bit about some of the science aspects of what we.
Okay. Thanks, Laura. So I get to talk about some of the preliminary data that we have so far in PALM. 2015 was our fire drill year, getting everyone enrolled, but we have been able to present some preliminary data at AHA sessions this last fall and have some additional data that we are going to be presenting this spring. So getting back to the science, remember our study questions were first to really look at to what extent have the new guidelines been adopted and where are there gaps in care in terms of primary prevention for cholesterol lowering. And we're talking about prevention of cardiovascular disease. So this is a really important area. Lipids can reduce the statins can reduce the risk of heart disease or recurrent heart attack by 20 to 30% in the right population. So when we're talking about lowering the burden of cardiovascular disease overall in the US, closing that gap between people recommended for statins who are not on it and the guidelines is potentially a really big public health question. So to get at the gaps in care, we looked both at the provider attitudes. What are providers saying they do? We looked at what providers did when we gave them hypothetical scenarios. And then we looked at where the rubber meets the road and saw what proportion of patients are being treated appropriately. The third study question was really looking at patient understanding of cardiovascular disease risk. The lipid guidelines focus a lot on a risk-benefit discussion between the patient and provider about the risk of cardiovascular disease and the potential benefits of statin therapy. And the emphasis is really to target the highest risk patients because those have the most potential absolute benefit from statin therapy. So how well do patients understand the risk of heart disease and how can we communicate that to patients in an effective way? And kind of the big picture, our fourth study goal is really how do we identify barriers to care for statin therapy so we can close gaps and improve CVD prevention? So when we talked to the providers, we had 800 providers across 150 sites that we activated who filled out our survey. And part of the reason why we had such high uptake is that before a site could get activated, 80% of the providers at that site had to fill out the survey. So a nice little carrot for the sites was that they could get activated faster if their providers filled out their surveys. So overall, we had about 78% physicians and about a quarter of the people who filled out the surveys were advanced practice providers or pharmacists. We had a good representation between subspecialty care of cardiologists and endocrinology and then primary care of family practice and internal medicine. Overall, about 3/4 of the providers said that they follow the new 2013 ACC-AHA lipid guideline. So the guideline's called the 2013 guideline. It really came out at the beginning of 2014. So by the time we were doing these surveys in 2015, it had been about a year that these guidelines had been out. So in addition to asking the clinicians, what guideline do you follow, we said, how has your practice changed in the last year? So we wanted to see key things that happened in the guidelines. Are they really affecting practice? So one of the biggest changes in the new guideline is an increased emphasis on prescribing high-intensity statins. So the highest risk patients, including those with diabetes, extremely high cardiovascular disease risk, and cardiovascular disease, are recommended for high-intensity statin. So when we asked providers, how has your practice changed in the last year? 50% of providers said that they're more likely to prescribe high-intensity statins than they used to be. Again, with the focus on calculating 10-year risk, another 45% of providers said that in the last year, they're more likely to calculate 10-year risk when they're assessing patients for statin therapy. So it looks like the guidelines are changing in general the way that providers are treating patients with statins and approaching cholesterol lowering. the concept of treating to goal LDLs was really abandoned in the new guidelines. That was something from the ATP3 guidelines that preceded the 2013 AHA guideline. And in fact, just over a quarter of patients, or just over a quarter of providers responded that they're less likely to treat to a goal LDL. So it looks like practices are changing in response to the new guideline. We looked a little bit deeper by challenging the providers and giving them hypothetical scenarios that would represent different facets of the new guideline to see how they responded to those scenarios. Those 4 scenarios are laid out at the top of this table. There's 2 that are kind of home runs. The first one is a high-risk patient with high cholesterol. This patient would have met guideline recommendations for statin under just about any guideline. And then the 4th column are patients with diabetes. Same. Under ATP3 and the new guidelines, these patients are all recommended for statins. And according to, across all providers, 93% prescribe statins for those that are high risk and high cholesterol, and 85% for those with diabetes. Then if we look at 2 more borderline scenarios, a patient who under ATP3 would have been low risk but have high cholesterol and been treated, or a patient who with high risk and low cholesterol who would not have been treated under ATP3 but would have been newly eligible under the new guidelines. And that's a lot lower. Only 40% of providers would prescribe statins for that high-risk, low cholesterol patient. So while providers are saying they follow the new guidelines, this sort of borderline patient that's newly eligible under the new guidelines compared with the old is not really getting treated. We then asked what proportion or how likely would you be to prescribe a high-intensity statin? And the majority, actually scenario 1, scenario 3, and scenario 4 would have all met criteria for a high-intensity statin. And among providers who said they would prescribe statins for that patient, about half to 2/3 would have prescribed high-intensity statin. So although providers are saying they follow the new guidelines, when we challenge them with hypothetical patient scenarios, it doesn't seem like their practice is actually meeting what the guideline recommendations are, particularly in those more nuanced areas. We then looked at the patients to see what's actually happening in true practice. And across 7,600 patients that we enrolled, and those who had prior cardiovascular disease, 85% were on statins. So it's pretty good uptake. That's in fact better than we see across national data. Unfortunately, only 33% were on high-intensity statin. So again, a big gap between what the guidelines recommend and what's going on in practice. When we look at patients who are at high risk of cardiovascular disease, only 65% were prescribed statins. And amongst those, only 12% were prescribed high-intensity statins. So it looks like, particularly in the primary prevention population, despite the fact that the majority of providers are reporting following the new guidelines, there's significant gaps in what patients are receiving compared with what guidelines would recommend. So how can we understand this better and how can we improve it? The guidelines really focus on understanding cardiovascular disease risk, patients understanding their risk and using statins to lower their risk. But how well do patients even understand what their cardiovascular disease risk is? The majority of providers said they use CVD risk to identify patients for statin therapy. Great, so if everybody's talking about it, patients should know what their 10-year risk is. We asked patients using a slider bar to estimate what their chance of having a heart attack or stroke is in the next 10 years. We then compared that with their estimated 10-year risk based on the new pooled cohort equations. And there's absolutely no correlation between what patients' predicted risk is and what their actual risk is, at like 0, none. And in fact, the scary part to me as a clinician is that the vast majority of patients dramatically overestimated their risk of heart disease. So why does this matter? Beside the fact that I have a lot of talking to do with my patients to really get them to understand what their heart disease risk is, what happens when I take this patient here, who says that my risk of having a heart attack in the next 10 years is 80%, and I say, no, it's really only 10. Well, what does that patient do? Is that really someone that's gonna then wanna start taking a statin or go on the cholesterol medicine or start exercising? So I think there's a really potential disconnect between what we understand as risk, patient understands as risk, and then how you translate that to motivating cardiovascular disease reduction behaviors. And this is an area that has not been well studied in the field of CVD. And given the emphasis of risk on the guidelines, it's something that we're hoping to explore more with PALM. Part of that is understanding how do you communicate risk. There's 100 different risk scenarios, but probably 4 that are used regularly by the different guidelines. There's the concept of 10-year risk, or what's your risk of heart disease in the next 10 years. That's what the 2013 guideline uses. there's a concept of lifetime risk. So the same person who's got a 10-year risk of 15%, which is high, has a lifetime risk of 50%. But how does a patient qualitatively consider those two differences? I suspect that if you show somebody that's their risk compared to that, they're going to think it's a lot higher. The European guidelines use 10-year risk of death. So that same patient has a 4-year risk of dying of a stroke or heart attack in the next 10 years. How does that change your qualitative understanding of risk? And then how do we communicate the expected risk reduction? Everyone likes these smiley face diagrams because they're pretty, but does it work? Or is the bar graph better? Or do people understand it better when you take away the figures and just talk about the numbers? So what we've done is randomize patients to different versions of the survey that show risk in different ways, ask them to qualitatively rate their understanding of risk, and also whether or not they'd be willing to take a statin therapy based on this type of risk reduction. And I think that's going to help us generate important information on how to create tailored cardiovascular disease risk reduction shared communication tools for the patient. So what's next for 2016? We're really trying to understand, use the data that we've collected at the patient, clinic, and provider level to understand how do we overcome barriers to cardiovascular disease preventive care. That includes really drilling down patient reasons for lack of access to statin therapy. Have they not been offered it? Are they afraid of statins? Are they not afraid of heart disease? Have they never even heard about statin therapy? Have they had muscle aches on one and they threw the baby out with the bathwater and they're not interested in cholesterol medicine at all? We've got really detailed information about patients' historical experiences, and we'll correlate that with their general understanding of cardiovascular disease risk and cholesterol risks. We're also going to look at gaps in what providers believe and what providers do. So how does a provider's understanding of the new guidelines and their beliefs about statins and cholesterol relate to how they're actually treating patients? And then, as I said, the data from the surveys is going to help us refine tools so that we can have better shared decision-making tools for when the rubber meets the road.
Thank you. I don't need that. So I'm going to spend the last 5 minutes here just kind of putting some of this together. I would probably just say that a lot of the innovation goals we spelled up front, I think we were able to achieve in the PALM study. But just trying to think about what this means beyond PALM here. I think there are quite a few future opportunities here. And you can, I think people can imagine a lot of these. I mean, certainly we've sort of proven the concept that an iPad can be used as a research tool, and now that we've got this technology, how can we build in things like adaptive enrollment, being able to randomize patients, not just the type of survey questions that they have, but actual randomization of treatment potentially. Can we pull in data from different sources? Now we're putting a device in the patient's hand. Can we have it stay in the patient's hands and use that to be able to do more longitudinal data collection? Or can we, I think you've already heard a lot about some of the things that can be embedded with devices in terms of wearables. All of these things are really in our future here for this. And then again, because we've kind of eliminated paper here, we're now talking real time. Okay, so doesn't that make our lives so much more interesting dealing with data on a daily basis rather than waiting for study lock and doing the analyses on the back end? So those are some of just a few of the opportunities that we see ahead of us based on this sort of proof of concept here. Along with that are some nice challenges that we need to deal with. I think you've heard some of these already been voiced earlier today. We are still tackling differences in regulatory compliance across different sites, let alone different countries. So I think those will still be things we need to work on. Data security is always going to be an issue. When you're tackling, and it's something we need to be very vigilant about, when you're tackling technology, and the folks in IT here at DCRI unfortunately know me quite well because everything seems to break down around me, but technology keeps moving forward day by day and we need to keep up with this. I'll tell you the iOS 8 transition in the middle of our study really threw us for a bit of a loop here. And then at the end of the day, coming back to the patient and to the site, how do we maintain that interest? I mean, the first time worked like a charm, but what about the next time and the next time and the next time after that? So these are some of the challenges that we need to think about here. Where do we go from here? I think we've really made the case for this being a really exciting project, and I feel really privileged to be part of this. I think we have a long road ahead of us. I think we can think about how this technology can be leveraged to assess both clinical needs as well as research needs. It can help us test out and evolve our research designs here. And then most importantly, I think these can also be used to sort of design effective education, whether it's clinical education or research education for our patients. This little icon on the side is one of the projects that we've been involved in now that is even modulating feedback to the patient based on the type of coaching that they want to be getting. So I want to say a big thank you to our study team. This last year has been really an amazing journey and really would not have been possible with our awesome team. And by team, I mean really quite a number of people, not just the study team. I think IT's been highlighted several times already in this talk. This is this would not have been possible without the firm support that we've gotten there. The innovations group was certainly one of the first groups to have brought the concept of using an iPad to us, and I think that was really started us thinking down this pathway here. We've had Seth and others from communications working with us to do those videotapes. There's a reason why I showed Anne Marie's tape and not my tape, because they like her more. So. The consent process was one that required a lot of work up front to be able to say, how do we condense a 6-page form into a 6-minute video? And we really appreciate our IRB colleagues there. And certainly all the coordinators out there and the patients who've worked with us on the study, their assistance has been very much appreciated. So with that, thank you very much for your attention. And take over.
So I think we have time for a couple questions if there are any. Shocking. Adrian?
So that was awesome. And in particular, what I like is the kind of trying to push the boundaries of having a better consent process. So, and just last week, the city group presented their recommendations for consent process, and I was actually kind of checking against the list of what you guys have done. And it really matches up with a lot of the elements there that are important. But the key question is, how can we get this implemented more widely? So, based on what you described and your experiences, and I know just, how much effort you guys put into working with the IRB, getting things going, how do we scale this up so every study does it? Maybe I don't know if that's for you, Tracy, or Eric, but either one.
Well, I think that's actually been sort of our question starting from month 2, once we've realized that this was feasible. I think the scalability is there. I think a lot of the pieces, the infrastructure that's built in place, and this is something that I've had lots of conversations with Jeremy and others about, is all of sort of the key infrastructure is there, and then it is fine-tuning the content to be able to adapt to different studies. I'll say that we've actually now showcased this a couple of times, and there's a lot of interest in sort of evolving this tool into other studies. There's also evolving this tool into some of the things that we've talked about before, more longitudinal data collection, potentially putting it into the patient's hands, potentially embedding interventions as part of this, and also doing patient education as part of this. So if you were sitting in clinic and you finished going through your 20-minute survey, wouldn't it be nice if we could actually start teaching you some things about, lipid management, for example? So those are the things that we're doing there. From a scalability standpoint, I would say that it's eminently doable. I think we would need to build up, we had to train our coordinators to be IT, sort of pseudo IT specialists here. They needed to be able to troubleshoot problems when a device malfunctioned or didn't function the way it was expected to. And I would almost say that the human component of this is a piece that we needed to, we didn't quite anticipate upfront, and we need to build that up in order to be able to do that.
So the only thing I'd add to that is just it is a challenge across the DCRI, right? Because what we do in each one of our studies, we often come up with some new innovation. And the only question is, how do we now disseminate that across to every other study that could potentially use it? And that's a challenge for us as an organization. We've got to work on it. The research conference like this is a start, but there are other ways we have to convey it out to teams more consistently.
Just to follow up on that, Tracy, is the fact that you implemented this across 100 plus sites. So how much variation was there in the consent process? What across those 100 sites? I mean, with paper forms, we were challenged with variation.
Yeah, so a lot of these sites use the central IRB, which helped with the consistency. So I will say that about 70 of 150 sites ended up using the video template and everything else the way it was originally designed. Now, the headers changed because of different practices, et cetera.
And this is incremental, right? Because initially when our own IRB, you'd be shocked to know Duke wasn't on the cutting edge, our own IRB first looked at this, they wanted us to read every single word on the form, which took 20 minutes, in a video version as the way to try to make the world better. We pushed back. The 20 minutes on the video form would leave us 0 minutes for the actual survey, decided that probably ratio wasn't a good one, so that we had to go to a different process.
I think that's where we actually try to use like city recommendations and what's going to be coming up for the revision of common rule to help push back on that, because I think it's great.
So I know we only have a minute, but I too would like to congratulate you for a great research conference and for studying the research process, which we are woefully inadequate at having done, and this is a great step. Along those lines, did you think about actually randomizing the sites to a traditional approach or to this approach to see what the impact would be in that way?
You mean a traditional like paper-based entry?
I mean, I think this
No,
is,
we just wanted to do the cool thing.
I think this is reasonably compelling, but I do think, but that, and it's not a criticism at all, because I think you've demonstrated some really great things, but that would be an alternative.
It is a great thing. There's a couple things I would say. We did didn't actually succeed in doing, but we did talk about the concept of actually looking at how the video versus paper-informed consent would change things. It didn't happen in this study, but we have planned to do it in other studies. Two, there's the idea of, we did the randomization within the tool itself, but there's lots of other, exactly as you indicate, ways in which we could sort of better see the effect of a given new technology on how the efficiency of a study went. Go ahead, John.
Yeah, just one other comment. So I presume you're planning on publishing these methods. I mean, one of the challenges that city has run into multiple times as we've looked through central IRB, informed consent, et cetera, is that there's not a lot out there published in the literature about
American
these
Heart
things.
Journal.
Yeah. So the more, there's not one methods paper here. There's 5 or 10 of them. If you think about it, about the informed consent process, about how you're collecting data, about central IRB versus local IRB. There's multiple issues that need to get disseminated.
One final question.
One of the things that I could see, and this is my first day at Duke, so I used to be at Abbott, but I could immediately see this as being useful in terms of the scalability of device trials, because it's exactly what you have already done is a large device trial, 150 sites, so I could see it immediately applying to that. And even the whole thing about the gentleman who mentioned about randomization to paper, I can already see that if I were Abbott, I wouldn't care, because we're trying to get rid of paper, because paper is very labor intensive, so if this would work. One of the questions I had is, in the cardiovascular device trials, they tend to be very low in enrollment for women. Do you think this kind of consent process, given that you got almost 50% women to go through this, it might help enrollment in some of the device trials of trying to get more women into the device trials?
That's a great question. We've kind of looked at some of the trial barriers for women versus men, and there are obviously a lot of common themes. Time and efficiency being one of those, and I think a lot of it has to do with trial design, but certainly the tools that we use to implement this, if we can shorten the amount of time that's necessary to participate in a clinical trial, that would be a big draw here. So I think what we saw here was pretty much a 50-50 gender distribution, and we're obviously very proud of that too.
The iPads were pink.
So there was some, now remember, every iPad also had a protective covering. We sent all the iPads out with protective covering because if you're like me, you'll drop it about 10 times a day, which is why IT loves me. But we did the uniform color. Next time we'll do some color variation and randomize that too. Thank you, everyone.